Am I audible? Is this working?
Yes.
Coronary angioplasty, stentings and bypass surgeries in multivessel coronary disease. What is the evidence today? This has been a debate for a very long time, and this is a very common cardiac problem that comes for invasive procedures in the elderlies. There have been different recommendation committees, but we are all overwhelmingly one-sided, with cardiologists being on the board and the surgeons being in minuscule minority, and the industry overpowering because of financial aspects involved in this whole game. So this was a problem in the past. Of late, and there have been lots of trials, and they have been very confusing. The technologies have been changing rapidly. With the emergence of drug-eluting stents, most of the old trials have now become obsolete, and hence some new age trials become important. This is a very funny picture of a patient in New York having had 60 trials learned from the past mistakes of the old trials. The newest trials were the CABG versus PCI ever performed. One was Freedom, which was in diabetics, future revascularization evaluation in patients with diabetes mellitus, optimal management of multivessel disease. And the other, more important, at a cost of $1.2 billion, floated by drug-eluting stent companies in cooperating centers in Canada, USA, and Europe, was a syntax trial, the synergy between PCI with taxes and cardiac surgery. Both using drug-eluting stents and minimally invasive surgery these trials have been initiated. These trials are complete and their results are out. The mother of battle so far was the syntax trial, which has been taken with utmost respect by everybody, because in this trial there are apples are compared with apples and oranges with oranges, where we do the angiogram and we actually score the morphological features on the lesions and make a score, the syntax score, and all the cohorts were compared by the scoring system, and this score has now become extremely popular. There are certain terminology which will be used. MACE is major adverse cardiac events, MACC is MACE plus cerebral events, and repeat revascularization means second time procedures again. The recommendation classes, if you recommend that somebody is a class 1 recommendation, that is ultimate recommendation, and if you say class 1A, that is the real classic recommendation. I cannot proceed. Can you help me? Yeah. The syntax trial, this was the scoring system, and according to the lesions, this was never done before. According to lesions, everything could be nicely stratified and scored. At 1 year end, the syntax trial, which had large number of patients, 18,000 patients across the entire Western hemispheres, involving very powerful people, it showed that the freedom from additional revascularization procedures, patients coming for additional stents, additional bypass surgeries, etc. The top line was bypass surgery, the lower line is stents. The gap was pretty wide. But 1 year is a very short time. Hence, and when this came out, there was a huge news in New York Times and everywhere that there is evidence now, newfound evidence, which favors bypass surgery. At the end of 3 years, the trial went on, and at the end of 3 years, surprisingly, the gap persists. The stents the major adverse events in the stents is the yellow line, and the major adverse events in the bypass surgery is the blue line. In summary, the syntax randomized patients 3 years, MACE rates were significantly higher for angioplasty or stents than bypass surgery, mainly driven by higher repeat revascularization in the stent arm. Significant increase in the infarctions, heart attacks, compared to bypass surgery at 3 years, driven higher in PCI-MI rate between 1 year to 2 year and 2 year to 3 years. The composite safety of death, stroke, and heart attacks remained similar between the arms at the end of 3rd year. The MACE rates at the 3 years not significantly different from patients with a low score and the low score favored a stenting, and a more than 22 favored bypass surgery. The problem in a country like India, where diabetes abounds, almost 60% of the patients coming for this kind of procedures have diabetes. Small stature people, smaller vessels, lot of diabetes, the scores are very high in our country. So not too many patients are suitable for angioplasty. I'll skip that. At the end of 4 years, the trial continued. And at the end of the 4 year, again, this kind of gap persisted. And if you eyeball this, the figures are still very wide, favoring bypass surgery. When this 4-year trial was, the results were out, this article in Lancet showed that this was quite dramatic still. At the end of 5 years, we thought that the vein graft will start going. And if the vein grafts go, the arms will come down together. But surprisingly, even at the end of 5 years, you see that adverse events with stents are still 36%, and with bypass surgery only 25%. This is because introduction of the statins and the high dose of statins, it is now realized, are keeping the veins alive much longer than expected. So both the composite death, stroke and MI, and also the other repeat revascularization rates are both much higher in stents. The freedom trial, and at the end of 5 years, the syntax trial has been rested, and there is a conclusive proof which is leaning in high scores towards bypass surgery. Freedom trial also had the same thing. In conclusion, for patients with diabetes and advanced coronary artery disease, bypass surgery was superior to angioplasty in that it significantly reduced rates of death and myocardial infarctions. And of course, without saying it goes, repeat revascularizations. There is another important study floated by the Journal of American College of Cardiology, and this study was called Appropriateness Criteria for Coronary Revascularization. This next graph summarizes everything. If you look at the green, A is appropriate, U is uncertain, and I is inappropriate. This side is bypass surgery, that side is stents. And if you look at all the cohorts, everywhere it is A. Bogged down by all this financial burden in Europe, and with the newer problem that Europe has been facing, there was a joint European Society of Cardiology and European Association of Cardiothoracic Surgery guidelines were floated by the support of European Union, and these recommendations are quite shocking. The recommendations say this side is bypass surgery, that side is angioplasty. And all the cohorts except one vessel or two vessel disease, where there is no proximal LED involved, are all class 1A indications for bypass surgery. And the other side you can eyeball, European Union. This was in 2009. Credo Kyoto, spurred by that, the Japanese put a coordinating center in Kyoto University, 27 cooperating centers, and they came up with their recommendations. And even their recommendations were exactly the same as the European recommendations, but the guidelines were same as the European guidelines, but surprisingly showed better outcomes with bypass surgery, even in the low syntax scores, less than 22 in multivessel disease. The syntax team also proposed the concept of heart team, that there should not be lopsided opinions and there should be a heart team formed in each hospital which will take decision on each patient. But nobody practices that today. Second thing is very surprising to me, even in academic centers like Jaydeva or All India Institute of Medical Sciences or PGI Chandigarh or the JNI in Pondicherry, I don't see syntax scoring calculated for any patient. Syntax scoring today is easy, there is a software, there is a calculator. But whatever angiograms reports that you will see anywhere from starting from tomorrow, you will never see a syntax score. And today, life is pre-syntax and post-syntax. And if syntax scoring is done honestly, there are hardly any patients in India who would have less than 22 syntax score. There are a lot of murmurs that it's cumbersome, time consuming, all are very busy. What about institutional guidelines? Institutional guidelines at least can be set up by all major institutions, whether private or government. There are no institutional guidelines anywhere. What about teaching institutes with large number of postgraduates and residents? Jayadeva Institute has got 28 DM candidates admitted every time. There's a huge population of these boys who can very easily do the syntax scoring. So also in All India Institute or most of these big government teaching institutions. This was a very important quote by Gersh and Fire in New England Journal of Medicine. He is a chair for Mayo Clinic. The angioplasty treats an isolated lesion in the proximal vessel. CABG bypasses the proximal 2/3 of the vessel where the current lesions and the future threatening lesions occur. This advantage of bypass surgery will persist and bypasses the entire disease bearing area in the proximal segment, and this will always persist. There are some angios that I want to show you which I have done almost more than a decade ago. This looks like a normal coronary angiogram. It is not. The normal coronaries are all gone, not seen at all on the angiogram. This is a left and right internal mammary Y graft done 14 years ago by me and a young guy, and 14 years later this angiogram looks like this, a beautiful macrocollateralization. This is a standard story of Lima-Rima grafts all across in most of the experienced hands. This is a radial artery graft put 12 years ago, aorta to coronary. The top that you see is a sequential anastomosis, diamond shaped, and down below it's a end-to-end anastomosis. It is so beautiful, so elegantly seen even after 12 years. This is a gastropelvic artery brought down from the abdomen around the stomach through a punched hole in the diaphragm to be anastomosed to the right coronary artery. This was a young jockey in Bangalore. 16 years later, this is such a nice patent graft on the PDA. The Indian dilemma, there is another thing that has come up, is fractional flow reserve. Fractional flow reserve will exactly tell you that where the blood supply is really deficient and there you can do the treatment. But the problem with this is that this is expensive. This is 600 pounds every time you do. And the problem is if you want to follow somebody with FFR, how often can you do it? And how practical it is in India? It is not practical. This is a modern recommendation by everybody. This is again is going to favor a section of industry which is going to be producing these catheters. Our patients, whether they are Bombay, Barshi, small place, big place, there are few native problems. There's a large number of them who pay out of pocket and they can't come back like this again and again for repeat revascularization procedures which are very expensive. Number two, these repeated reimbursements are unlikely to be respected in most of the cases by the payers. Number three, the in-time effective emergency angioplasty is very difficult in our country because A, financial, B, traffic problems, C, the patient's cultural problem themselves. So if we say that we will go conservatively and then we will do whenever there is a problem emergency angioplasties, that is what Courage trial said, that is not practical in our country.
You have a minute, doctor.
There's a high prevalence of diabetes and it may put the hospitals on back foot with the payers. Hence, it's a good idea to do CABG in multivessel coronary artery disease rather than putting multiple stents even in the elderlies. And now with the emergence of hybrid labs in most of the major centers, one can do minimally invasive surgery and just put the internal mammary to one vessel, and other vessels we can still do stents if it is feasible. And even in a nanogenarian or person who is reaching 100, this can be quite a feasible proposition. Because the time is running short, I'll just skip, but these are all cynical comments by most of the majority journals saying that despite of so much of overwhelming evidence, the ground realities are different because of involvement of industries. So these are again editorials after editorials. And these are all very major, powerful journals. So why is PCI replacing CABG against best evidence? A, the cardiologist is the gatekeeper, and this may produce a conflict of interest in terms of self-referral. B, the disindigenous presentation and inappropriate application of results of randomized trials in highly select and atypical groups to the whole population. And lastly, the result of what happens when evidence-based medicine is challenged by multi-billion-dollar industries. So what are the correct indications? If you do an angiogram and if you find that there is a left main coronary artery disease, there is a diffuse triple vessel disease, especially with LV dysfunction, and is a diffuse double vessel disease involving proximal LAD and non-stentable proximal LAD, they all should go for bypass surgery by today's standards. In India, in a country where most of them are paying out of pocket, I would have a lower trigger for bypass surgery in patients who are non-reimbursed. Thank you.
Thank you, Dr. Vivek. I hate to say this, but I think we are up against time. If you have one short question, no comments please, then I would take it.
These have been nicely dissected into all various cohorts, and there are always apple to apple. And throughout all the cohorts, but most shocking are the European Union and the Japanese, where the database is absolute recommendations, especially Japan.
Okay, thank you very much.
We'd like to thank Dr. Jawali for his presentation. Let's give him a round of applause once again. Thank you, Dr. Jawali. May I request Dr. Arora to honor Dr. Jawali with a token of our appreciation.